Well, it's a great pleasure and an honor to be part of this symposium, combined symposium today. And yes, I didn't thank Mark particularly when I got this title, Challenges, Barriers, Opportunities, and Mindsets. Greetings from Auckland. You're welcome there, not all at once, no conflicts. So I've been asked to talk on these 4 areas, and to be honest, I just changed it to this. It was a lot easier. I'm going to cover 12 issues very quickly. Some of it is a review of what we've already heard, but I hope that I'm going to be able to provoke you a little bit. I was provoked back in the mid-90s. I just returned from Edinburgh where surgery was king. Pancreatic resections were done up front. And Doug Evans came by to Auckland, left his textbook, and said that neoadjuvant therapy was the future. I said, well, why aren't you doing randomized controlled trials? You have the volume in MD Anderson. Why don't you do it? He said, today we have lost the equipoise. It's taken more than 20 years to have the first randomized controlled trial. So I'm going to go through issues very quickly. I'm conscious of the time, and some of this is obvious. Pancreatic cancer remains a major challenge, and there has been, despite the positive comments today, relatively poor progress overall. The UK data, you're very familiar with the league tables. Sitting at the very bottom is pancreatic cancer. I like this way of presenting data, which the length of the arrow indicates how much improvement has there been in survival for the various cancers. If you look at the very bottom, pancreatic cancer line is not even long enough to have an arrowhead. Overall results, abysmal. And I was thinking about this talk going down to the lake edge in Lake Geneva there and seeing this very provocative sculpture. And one could be tempted to feel this way sometimes with pancreatic cancer. Second issue is that surgery has a limited role, and I would put to you a diminishing role in the treatment of pancreatic cancer. I said I was going to be provocative. We know that only the minority of patients can have resection, even if we include borderline and locally advanced. We know that resection on its own results in poor survival, and we're very dependent on the adjuvant and neoadjuvant options. And recurrence, both local and systemic, occurs in the majority. Third, increasing radicality of surgery is unlikely to improve surgery or improve survival anymore. And we've talked about the importance and our focus as pancreatic surgeons on trying to shift that curve. And I did like this paper, which looked at progressive decades and that survival curve. And if you look at it, each decade there was an improvement. But there's a ceiling effect. We can only do so much with surgery, despite the improvements of technique, safety, et cetera, et cetera. So more radical surgery is not likely to shift that curve much more. And certainly not doing robotics or laparoscopic surgery is going to make any difference to this immutable curve. And so I would say to you that the golden years of surgery first are now gone. This curve will be etched as hieroglyphics have been. What are we going to do with the rest? And the borderline resectable group is in this red group, and it's, really where our focus needs to be. Fourthly, as been said already, pancreatic cancer is almost certainly systemic at the time that borderline resectable disease presents, and we know about the ubiquitous perineural invasion. We've talked about the micrometastatic disease. This is a systemic disease at presentation. Fifthly, pancreatic surgeons need, I'm not saying to you specifically, but I think we've needed a mindset change. And we can look back here, we've been quibbling, if you like, in the foreground about whether we should take the artery or the vein or whether we should do an extended lymph node dissection, et cetera, et cetera. And we've really kept our medical oncologist colleagues in the background. We can certainly take lessons from breast cancer. And I don't know why this happened 20 years ago and it's just taking us 20 years to come to this point. Halstead, of course, had that concept of more radical surgery is the answer to breast cancer. It was Bernie Fisher that turned everything on its head and said, no, this is a systemic disease. We need a biological concept of this cancer, and therefore we're going to do some systematic trials. And he did some beautiful studies, didn't he, looking at neoadjuvant therapy prior to less radical surgery. Number 6, The benefits from neoadjuvant therapy in borderline resectable cancer are actually encouraging, but level 1 evidence has been lacking. Of course, there's lots of data, and we've heard some very good data today, which is very encouraging. If we undertake neoadjuvant therapy, chemotherapy alone or combination therapy, we're likely to have a higher proportion of patients that are resectable, that complete their chemotherapy, that have negative margins, and indeed have improved overall survival. But none of this was based on level 1 evidence. Highly interested centers with high volumes have been able to achieve that. And so it was with great pleasure, really, and I had to change my talk when this came out, this randomized controlled trial, which Scott presented to us. It was small. Gemcitabine is not what we would consider first-line neoadjuvant therapy anymore. Reasonably aggressive external beam radiation therapy, 2-year survival, the endpoint, and an interim analysis, which resulted in a premature closure of the trial. Intention to treat analysis demonstrated that the neoadjuvant therapy approach was better and that the resection R0 rate, not as good as MGH, but the R0 rate was definitely better with neoadjuvant therapy. And so early termination. And there was clear and persistent separation of the survival curves. 7. We actually don't know what is the most effective neoadjuvant therapy regimen, and I think, Scott, you put up the questions and all the different studies that are going on now to try and work out this, not only what to give, but what sequence to give. There's a lot of unknown questions, but the reality is that the response rates are improving. And I was interested in this study that, again, just came out this year. Here's a retrospective study looking at both borderline and locally advanced disease combination therapy, and they looked at those patients who had pathological complete response, no viable tumor, to those that had a near complete response and a T stage of less than 1 centimeter and node negative and limited response. And you can see here that the pathological response was present, complete pathological response was present in 10% of patients, and the median disease-free survival was just 26 months. But that was significantly better than those with near complete response. But the disappointment, is it not, that even with complete pathological response, after relatively aggressive combination chemotherapy, radiotherapy, that we had a disease-free survival of just that much. Again, Christina's data from MGH are very encouraging and better than that. When they did multivariate analysis to try and work out what were the prognostic features for disease-free survival in this study, it was pathological complete response, but FOLFIRINOX was important, and patients who had node-negative disease. No real surprise there. But what you see here is that the survival curve is better in those that have a complete response. And to be honest, I had never seen a complete response prior to FOLFIRINOX. Number 8, if neoadjuvant therapy is beneficial for patients with borderline resectable disease, and indeed locally advanced, as we've heard, why is it not appropriate for all patients, that is, including resectable patients? The argument goes like this. If the disease is systemic in the vast majority, if local treatments are relatively ineffective, if neoadjuvant therapy is effective, at least in some patients, and if we cannot accurately select those patients who do benefit from neoadjuvant therapy, then why are we not considering this for all patients? So the meta-analysis from the Dutch Pancreatic Cancer Group was presented again just earlier, a relatively large study. 50% had neoadjuvant therapy, and this was for resectable or borderline resectable, not making a distinction there. And what they found in the meta-analysis was that the overall resection rate was better with surgery first, that the overall R0 rate was better with neoadjuvant therapy. They couldn't distinguish between the R0 rate on an intention to treat basis, and there was a pathological lymph node benefit for those who had neoadjuvant therapy. Now, they went on to perform the randomized controlled trial, again, that Scott presented. This is for resectable and borderline resectable disease, a multi-center randomized controlled trial. Gemcitabine and radiotherapy, just 36 gray this time. Primary endpoint, overall survival, and the usual secondary endpoints. Based on an intention to treat analysis, neoadjuvant therapy was associated with better overall survival, a better R0 resection rate, disease-free survival benefit, distant METs-free interval period was longer, and local regional recurrence-free interval was longer. Similar resection rates, subgroup analysis indicated a benefit for median overall survival. This is really encouraging data. Number 9, if neoadjuvant therapy is not actually appropriate for all people, then that's when we're going to need to have a definition for borderline resectable. We've heard today that the distinction between borderline and locally advanced isn't what it used to be. And now what I'm saying is, well, actually, we maybe don't need to make this distinction between borderline resectable and resectable, if indeed the approach that we're taking with borderline resectable is appropriate for all. And of course, we've got this problem because we've got at least 7, probably more, ways that we define borderline resectable disease. Enough of that at the moment. My concern is really that why are the definitions for borderline resectable disease all based on anatomic criteria alone? We know what factors influence outcome. We know that there are anatomical factors and there's surgical skill involved here. We know there are patient factors. We know that there are biology or tumor factors that are important. And the ones that we can really influence, of course, are the first 2, selecting our patients well and doing the operation well. The concept of including more than anatomy goes back to MD Anderson, where they have an ABC approach. They look at the anatomy, they look at the biology as best they can, and they look at the condition of the patient. And this kind of approach, taking a more holistic approach to the decision about whether this patient represents resectable disease or not, is important. And it was important enough for us to consider including this in a consensus definition for borderline resectable disease, which we published just this year. And in this, we've looked at the anatomical definitions, and the difference really here from the others is that we also included the inferior border of the duodenum as an important marker of the extent of venous involvement. And the diagram you can find in that. The biological definitions, we're really limited here. What can we really look at to determine the biology of our patient's disease? And in this consensus definition, we looked at CA 19-9 and whether the patients had node involvement or not. And then in terms of the patient's physiology or condition, we looked at using ECOG, and you can see that if the ECOG score was 0 to 1, there was a significant difference in outlook median survival than those who had a score of 2 or more. And so you can kind of put this together, resectable, borderline resectable, locally advanced based on anatomic, biologic, and conditional factors. But the reality is that at this point, while I think the concept is attractive, it's somewhat cumbersome and difficult to apply. And of course, what I really feel is most important is that we're really failing in that middle ground there about having good biological markers of disease. And of course, this needs to be tested with prospective validation. Number 11, the anatomic criteria which we use for staging and restaging are really very difficult to apply after neoadjuvant therapy. And we know the reason for that. These cancers have a significant peritumoral desmoplasia. Claudio Bassi was talking about that. We can't distinguish that often from tumor extension or post-neoadjuvant therapy inflammation. So it makes it very difficult with restaging. But there's really no turning back at that stage. If we don't see advancement of disease, if we see, particularly if we see a lowering of the CA 19-9, we're really committed to taking this patient to the OR. We run the risk of a higher positive margin rate, although that hasn't been borne out. There's maybe more non-therapeutic venous resections, but we've heard that that doesn't really increase the complication rate. But there is the propensity for over-treating some of these patients with an open and close. What I haven't heard anybody talk about is what is the number needed to harm for neoadjuvant therapy with borderline resectable pancreatic cancer. And lastly, I just want to comment on this other issue, that we really need a new approach to staging and restaging for borderline resectable disease, indeed if that concept is going to have any long-term benefit. So the paradigm has to be not just reliant on anatomic criteria, but we want to take the biology of the tumor and the physiology of the host into consideration. And of course, a new approach to staging is going to help us. We're going to better select patient subgroups for treatment. We're going to better select those patients for more effective treatment for them. and we'll have a more accurate prediction of outcome. You know about the heterogeneity of pancreatic cancer. I mean, there are just so many pathways and so many ways in which we can describe this, what to the pathologist looks like the same cancer. You'll be familiar with this paper from Nature in 2016. The Australians led the way here with 456 surgically resected patients. They looked at an integrated genomic, epigenetic, and transcriptomic analysis and a systems biology approach to the analysis. They found 32 recurrently mutated genes involving 10 different molecular pathways, and they're able to define 4 discrete subtypes of pancreatic cancer, each with distinct mechanisms of evolution and therapeutic relevance. I think this is just the first attempt to do this, but it was striking that we had, when you look at the heat map, and I don't have to go through the details, you can see those 4 groups are quite different, and yet they looked just the same. And of course, their survival curves were different as well. And so really the goal, what's our goal? The goal is really for tailored therapy for pancreatic tumor subtypes, rather than trying to select patients on anatomic criteria for neoadjuvant therapy because we define them as borderline resectable. Anatomic criteria is not where it's at. We've got to get these biologies markers to work for us. That's the future, but I hope not too far away. So just in conclusion, let me say that, go through some of the points very quickly. Surgery, I think, has a limited role, a very important role in a subgroup of patients, but overall, probably as we get more effective neoadjuvant therapies, there'll be a diminishing role for surgery. Anatomic criteria are not adequate for the definition of borderline resectable disease. It doesn't really determine this, and Claudia was talking about the location of the tumor issue is important. It's the biology of that tumor, not the location of the tumor, that's important. Level 1 evidence is starting to arrive, and that's exciting, and it is a new era for neoadjuvant therapy on the basis that we have good data to work from. We still don't have the optimal protocols. People are trying different things in different places. We probably need more cohesion, more collaboration. In time, neoadjuvant therapy is, I think, going to be considered for all patients with pancreatic cancer. A surgery-first approach is going to be retired. I think it's well on the way to that now. New approaches to restaging are going to be necessary. We need to somehow get a handle on the biology of the cancer, and that's going to be essential for tailored treatment as we go forward. Thank you very much.
We had an outstanding presentation, and now we open the questions to the audience. Is there any question for the panel? Please take advantage of those experts. Please identify yourself, the name and the service. First in the back, and then the professor will be the second one. Please.
Yeah, Radenkovic, Belgrade, Serbia. It's a really great honor and pleasure to be here and listen such big experts. Thank you all of you for a very nice presentation. I have 2 questions. It can be a little bit provocative, but I expect that we need this. The first question is how we can define the subgroup of the patients who will not respond to neoadjuvant treatment. Then my second question, because those patients are lost. And it's not easy to explain to those patients when you come to my office to tell them you are going to neoadjuvant, especially you're talking about the operable patients. How I'll tell them, I will give you neoadjuvant treatment, but maybe during the course you will be inoperable. It's not easy to explain even if you put yourself in the position of the patient. My second question is how to identify or what will be the message, the whole group of this audience, what should they do? What will be your proposal for the neoadjuvant treatment? Because you see, all of you show a lot of studies, a lot of new regimens, and whether it's FOLFIRINOX and what is your proposal for take-home message? Thank you very much.
Christina, we can do together.
I don't mind taking that first point. I think it's really very important. These are the patients who you give neoadjuvant therapy and they progress and they can't go on to have surgery, which of course they've had their mind set on surgery, and you've put them off surgery to give them something else first, and they become very disappointed. From my experience, we need to talk to these patients up front and prepare them mentally for the fact that they will have the potential to avoid unnecessary surgery in the face of progressive disease, which would have happened anyway. So I think it's all about how we set our patients up before giving them neoadjuvant therapy.
Can I just add something to that? Just one other thing to that first point is that we know from those survival curves from upfront resectable disease that 30% of our patients who we operate on are pretty much dead in 12 months. And we should never operate on those patients. And I think having that conversation, and I agree with you, because the patients come and they want an operation, and then if they progress, we haven't controlled their metastatic disease, right? And they probably already had micrometastatic disease, and the patients who don't respond, by us, we switch them to gemabraxane. But if they failed FOLFIRINOX and failed gemabraxane, I don't think that a local operation is going to be able to help them live longer.
One of the criteria we have to use to bear in mind when we watch to the data coming from the neoadjuvant group of patients is that in this way we are going to select the patients that are going in the worst way independently or upfront chemo, radio, surgery, everything, you know. We are going to select the patient with a neoadjuvant approach. So the benefit we see in this subgroup of patients is because this kind of selection. Of course, we have to inform the patient that unfortunately everywhere in the world, in Boston, in Verona, in New Zealand, everywhere, there is 10, 15 of patients that go directly without being sensitive to any kind of treatment. That happens in every kind of cancer, but particularly in pancreatic cancer.
I think we have to identify more objective measures for quantitating response, and I think some of the good studies recently have shown that using the CA19-9 in combination with the PET response are surrogate markers for getting control of the systemic disease. We've shown that it's not just the drop in the CA19-9, but the kinetics of the curve. It can be predictable of longer survival. And I think some of the work, for example, by the Hopkins group with the tumor circulating DNA may be another way of measuring response to therapy to identify those people that have the best chance of an outcome after an operation.
Next question here in front.
Luis Arnaldo Zuta in Brazil. When you do the neoadjuvant therapy, the surgery is more complex. There is any impact in the indication in conventional, laparoscopic, or robotic surgery when you do neoadjuvant therapy?
To be honest, I have no experience in terms of robotic or laparoscopic surgery after neoadjuvant treatment because we don't do Whipple procedure in a mini-invasive setting. So I cannot answer to your question. We have few cases in the left side surgery of the pancreas that we do by laparoscopic and robotic in robotic setting. I don't know if my former co-worker Giovanni Buturini, there's a very famous robotic surgeon, has experience in the field of Whipple procedure after chemo radio. I don't think it's so different than in the open setting. Sometimes it's more difficult, but generally speaking, is safer because the tissue is stronger, the anastomosis are safer.
I think we need to ask Mike Kendrick because when we do operate on these patients, most of the large series show that about 40 to 50% require a venous resection. So if you're not capable to do that safely laparoscopically, then I think the operation should be done open.
Next question.
Osama Hamid from Jordan. Thank you very much with this excellent panel and presentation. The whole thing is going around, biology is the king, Professor Black-Cady, selection is the queen. And I think what we're doing right now is just trying to select best performers to do at least locally advanced and borderline resectable. My question to the panel, do you see a rule with better selection for metastatectomy for oligometastatic disease in patients who are with pancreatic cancer who is responding to therapy? You know, the Heidelberg group had published recently some sort of prolonging survival, and I think what we're doing is prolonging survival and pushing the survival curve, and we're not aiming for cure. But do you see there is a rule for metastatectomy for oligometastatic disease on those who are responding to treatments? Thank you.
Personally, only in the context of a well-controlled clinical trial. I don't think we can justify doing that outside of a clinical trial.
I couldn't agree with Scott more in terms of doing it in a controlled trial, but I will say that we have done it, and it's usually been in patients who have had a significant time interval between the resection of their primary tumor and the metastases, and most of those patients who we've done have been BRCA1 or BRCA2 mutant patients, where they develop one solitary liver metastasis, and we do a liver resection, and then we put them on a PARP inhibitor. In terms of lung metastases that have been outside of the BRCA mutation cohort, we have done lung resections for solitary metastases, because it does seem that the patients who develop lung metastases over liver metastases or peritoneal metastases tend to have a longer survival. But it's usually if they have one metastasis and not more than one.
I have shown our data is about 2% of 1,500 patients, so nothing else to declare.
Okay, 3 more questions, please.
Thank you. Kito Fuzai from London. Really enjoyed it. And I think most centers, most pancreatic surgeons who have now adopted the treatment that you suggest for borderline resectable disease, in fact, we face a situation where the trials which are coming through are validating and ratifying an approach which is already established in clinical practice for borderline resectable cancer. My question to you is that there is a very small subgroup of patients who present with borderline resectable disease and they get treated with a sequential chemo and chemotherapy. A very small group of these patients do respond to chemotherapy, but they can potentially progress on chemoradiation. And we're certainly seeing this happening in 3 patients in our experience. My question to you is, do you suggest to restage and resect them after FOLFIRINOX if they become resectable, for instance? Or do you want always to continue and complete the sequential chemo and chemoradiation, considering that there is a small population who will progress on chemoradiation?
I think, I mean, we've all seen patients progress. About 20% of patients progress on chemo alone because they're resistant. And we've seen patients on FOLFIRINOX progress and they get switched to Gem/Abraxane and they respond, and vice versa. So I think most of the trials argue for staging after each sequence. So chemo, restage. Lack of progression, you go on to chemo RT, restage before going to the operating room.
Yeah, we do the same thing. We usually give 4 months of chemo neoadjuvant, and we do it every 2 months during chemo and then after chemo radiation. But I think the radiation question is a very, very big question, and some of it is institution dependent. I think the Alliance trial that got presented will help us answer that question in the neoadjuvant setting for borderline resectable disease. And so hopefully in the next, they'll probably present the interim analysis very shortly because we've talked about it at a conference call. And so I think that it's going to get presented, and I think that will help answer that question as to what the role of radiation is.
Well, we have the first and the second scheme, FOLFIRI or Abragem, we call, okay, and vice versa, as said before. And very recently we start again to reconsider radiotherapy that was abandoned in our setting for many, many years. And this is because the new technology is completely different from the old one and the ancient one, I mean. So we deserve the radiotherapy approach to the so-called stable disease, as the medical oncologist said. Whenever we have a clear staging or downsizing of the tumor after chemo, a subgroup of patients experience radio before surgery in a very short period. But it's a new behavior we follow since very few years, and I have no concrete data. The feeling is very good, but you know that we cannot trust on the feeling.
So we have time now for another 2 questions, and maybe only one member of the panel respond instead of all. Then we can be on time.
Hello, sir. I am Hashim Rabbi from Dhaka, Bangladesh. I have 2 questions, 2 simple questions. If the primary tumor is resectable and there is a liver met, how do you approach? And the second question is, if the is the borderline resectable tumor patient is presenting with recurrent hemorrhage, how do you approach to these 2 patients?
I understood only the first one. Liver mets, resectable disease. Okay, there is a doctor called medical oncologist. This is perfect for this patient. No surgery, no question. Please forget it. The second question.
Is the second question post-operative hemorrhage?
No. The patient with a borderline resectable tumor, but presented with repeated hemorrhage.
Presented with hemorrhage?
GI hemorrhage.
Oh, with GI hemorrhage. Then you'd work out as per normal. I mean, if you did find that the patient had invasion of the duodenum of the pancreatic cancer, then you might want to palliate that with radiotherapy as part of a neoadjuvant therapy, but that's locally advanced disease most of the time. But you'd work it up as per a normal upper GI bleed, and if you found a malignant cause for it, you'd make decisions accordingly.
Last question, and then the final remarks from Dr. Callery.
Thanks for your talk. I'm Vichin from Dallas, Texas. I had a question about new technology and IRE. I mean, there was no discussion about IRE. I'm just wondering what your thoughts were in this setting.
Okay, we are talking about clinical experimental setting.
Yes,
we are still in that area.
Sure.
We are talking about clearly not resectable patient. I have experience in terms of phase 1 study, is feasible, is safe. We need more and more time. We need to select patients. Also in this field of ablation, generally speaking, we are now aware that a subgroup of patients is a very good group of patients to be treated this way, but we need to know the biological behavior of this tumor, watching to specific proteins and genes like the PDAC4, etc. Because if the tumor is a tumor that biologically tend to stay and to grow locally, it is a good tumor to be treated with ablation, IRE or thermoablation or no thermal technique, probably is the same, okay? But if it is not a tumor that tend to grow locally but have a more spreading behavior with mets, etc., probably is not the best way to use this kind of new approach. I think that in 3-5 years, we will able to show more scientific data.
Thanks.
Thank you. Just one final clinical point that wasn't brought up this morning for resectable disease and neoadjuvant therapy. We've seen a number of patients lately who've come in just kind of too sick to go to the operating room. They've had pancreatitis associated with their stenting. They've had weight loss. They've had malaise. We've treated those patients with upfront chemotherapy, restaged them. they're feeling better, they go to the operating room, they do a lot better. So keep that in mind. Our professors will be available to everyone, and we want to thank you for attending. Thank you.